Not many people on tonight.
No, I think we discouraged them answering the messages in the chat.
Shade.
The link. Oh, there's a good few coming in now.
Wait for 3 more minutes.
So Cheryl, you'd rather we I copy all those questions and then I post them on the group and you answer them in your time?
Yeah, I mean, I'm happy to do a full hour, but I honestly feel like I'm drunk.
So you want me to copy the questions on?
Don't even know how I'm still functioning, to be honest. But yeah,
Right, we'll see how we go then.
If anyone asks me questions, yeah, I'll do my best to answer them. But if they're a bit much, then put it in the chat. Can everyone see this slide? It's just 2 slides, so I'm not gonna share it full screen.
No, we're only seeing your folder.
Yeah.
Can you see it now? Maybe there's a bit of a delay.
Nope.
We can't see.
Okay, let's try new share because this is what happened last time. You have to share only the screen that has PowerPoint.
Something's coming up now.
Yeah.
Yeah. Okay.
Yes, I can see it.
So you have to click new share. Okay, dokie. I think I'll get a start then. So hello, everyone, and thank you very much for attending the session. I'm really, really tired. Please just bear with me, but I will do my absolute best. I want to give psychiatry some justice. This first slide or this first PowerPoint presentation that I have up only has 2 slides, and this is very, very brief. I've given 2 really comprehensive documents. I've shared this in the main group, in the chat, that has everything you need to know. So I've outlined it in precisely the order that you need to do everything, and I've given it to you on a silver platter. All you need to do is deliver it. People have mentioned that they don't think that it's enough, that 9 minutes is enough time for psychiatry history taking station. 9 minutes is all you have, so you have to make it work. It is absolutely doable. So most postgraduate exams have 10 minutes for the psychiatry history taking. So the Royal College of Psychiatrists, the postgraduate exams, it's the standard for the Part B practical exam. It's 10 minutes. In real life, you can go up to 30 minutes, 1 hour, however much time you want. But in the exam, you need to time yourself when you're practicing this station. Okay. So the main components of this station, I've put psychiatry history taking station, but that's actually incorrect. It's psychiatry assessment. And psychiatry assessment has 4 main components, and these are the main things that you should aim to cover when you're doing the station in real life. Okay, so your initial assessment is basically your psychiatric history taking. That is basically you just working through the questions in order. Okay, Then comes your mental state exam. And I will explain in detail about the mental state exam. So this session will focus on the mental state exam, and I will explain certain parts of the mental state exam in detail, such as perceptions, which I think might be a bit difficult for people to reconcile with. The risk assessment, you must do a risk assessment. This is not a fail point in the exam, but it is really important that you do a risk assessment. You need to know, is the patient a risk to themselves and or are they a risk to others? The impression and the summary at the end, you don't have to do a really long geeky medics kind of 2.5 minute spiel of what you've done. It's just as simple as one sentence, a brief impression and summary. And you will do this impression and summary only when the examiner asks you a question. And the examiner will definitely ask you a question in the station. The examiner will ask you, what is the diagnosis and why? Okay, so whatever your answer is, you need to motivate. And you will motivate by mentioning the things that you've come up with or you've elicited from the assessment and the mental state exam. Is that clear to everyone?
Yep.
Yeah. So I'm going to close that one and I'm going to open my other slide. So if you want, I can just go through briefly the rapid psychiatric assessment guideline that I've shared in the group as well. Maybe if anyone has more specific questions about this guide, then feel free to ask. I'm just going to share that. Okay, can everyone see that?
Yep.
Yes.
Yeah, fantastic. So it is 6 pages. Don't get alarmed. You do not have to ask every single question. This is a guideline, and the guideline is in the heading. So it is a guide on what you are meant to do or what you should do. It's not a guide on what you have to do. So you can, of course, tailor anything and everything according to what you need and what you want, okay? So as I've shared in the PowerPoint presentation, I've got the 4 main headings here. So the initial assessment and history taking. So these are standard history taking components. You're presenting complaint. Why are they there in the first place? Why have you come to hospital? Why are you here? Or how have you come to be here today? The history of the presenting complaint. Tell me more about that. When was the last time? How did this develop? How has this affected you? Do you want to be here? Past psychiatric history, we always need to ask this. Have they had any contact with mental health services in the past? That will give you a good impression of the patient as a whole. So are they a regular user of mental health services, or are they just there presenting for the first time? So basically you have a blank slate in front of you. Yeah. Remember, anything that you ask and any answer that is given, you need to elaborate a little bit. So if they say, yes, I have had contact with mental health services, so yes, I've been, the home treatment team have seen me, or yes, the community team have seen me, then you can ask why, when, what for. Your past medical history, including your medications and allergies, is really, really quickly done. This is not a detailed medical history like you would take for medical or surgical history taking station. It is, do you have any medical problems? Are you on any regular medications? Do you have any allergies? That is it. Move on. You do not have time to stay or get stuck on one section. Is everyone okay with this so far? I mean, am I speaking too fast, or are my words slurring a bit?
It's
The
fine.
second bit, yes.
It's fine.
The space is okay.
Hey, sorry, but my voice has been off all day. Family history, quite important. So most patients with psychiatric problems have a positive family history of mental illness in their families. Very interesting to note. And of course, try and find out if there's any serious medical problems in the family. If they are a bit reticent, they don't want to say anything, just ask about diabetes, hypertension. Important if you're thinking of considering antipsychotic drugs, especially the atypical antipsychotics, which have cardiometabolic side effects. You can ask about cancers, so you're thinking about your hypercoagulable states a bit, and epilepsy, okay? Not all of them.
I've got a question here. So for instance, if the presenting complaint is sleep disorder, right? And you end up realizing that is because of low mood and depression. Do you go straight into like the question is any history of mental illness in the family? Or do you like sugarcoat it in any way?
So do you want to elaborate on that history of sleeping disorder right there and then?
Yeah, for instance, so somebody comes in and the prompt is has come in because wants sleeping pills, right? And you start taking the history and you ask like, well, how's the mood? And you realize it takes down the turn of psychiatry history taking. So you just start with this initial assessment and you go straight into any mental illnesses in you and your family, like straight like that, or are you sugarcoating it in any way?
No. So I would focus on their main issue first, get that properly done, because remember, if that's something that the patient actor says, that's what the patient actor and the examiner want from you in that station. So you should stick onto it like a dog with a bone. Don't let it go. Get all that you can out of that statement, and then just kind of work through everything to show the examiner, yes, I know what I'm talking about. I know how to do a psychiatric assessment. Does that make sense?
Yeah.
Yeah. Don't leave anything for the end. If you think something is important, you elaborate on that right there and then.
Thanks.
So family history, childhood and personal development. You can just ask one simple question. How were you as a child? Or how was your childhood? So you don't have to ask all these questions. These are just very, very detailed questions. Gives you a good range of what you can ask, not what you should ask. And I want everyone to be very, very clear on that. You should not be asking every single one of these questions that I have. This is just a guide on what you can ask, not what you should ask. Education, are you going to school? Are you in college, university? Are you in trade school? Employment, do you work? How do you get money to live? Psychosexual and relationships, just ask it straight out. Are you in a sexual relationship? Are you in a romantic relationship? Any problems with that or any difficulties with that? Now you need to read the patient's expression. So this is, even for the UK, this is sensitive, right? Most patients, I find, particularly males, don't really like talking about this. Females generally open up. Maybe it's because I'm a female doctor. Males are a bit more distant and guarded, so you kind of have to spend a bit more time with them. I personally do not think they will give you a sexual problem in the exam, but you just need to ask about it. Social, quite important. Are they living in a house or are they a rough sleeper living on the streets? Yeah, any issues with the council, like council housing? Again, how they finances, are they getting enough to eat? Okay, can they buy food? Any problems with the law before? Drugs and alcohol, illicit drugs and alcohol. Ask this very specifically. Any illicit or street drugs, and are you drinking and smoking? They usually have positive drug, alcohol, and smoking histories. Your pre-morbid personality, these are the range of questions that you can ask. All I ask is, how would you describe yourself before coming in today, or before developing these feelings, or before getting ill? It's just one question that you need to ask. And wrap it up. nice and snugly, do you have anything else you want to say to me? Or do you have any other questions you want to ask? Got that?
Yes.
These are the components of the mental state examination. I've got a separate PPT explaining in detail about certain components of the mental state exam. This is every possible question that you can ask underneath that specific component, or every single thing that you can elicit. Okay, obviously you cannot ask questions about appearance and behavior. You need to be observant for that part. Appearance and behavior and speech. And mode for the objective assessment. Does anyone have any questions specifically about cognition, cognitive testing, and or capacity? Because I might have recalled something in the chat. Questions about cognitive assessments and capacity, whether capacity is tested in this in the psychiatric assessment.
There's nothing in the chat. Sorry, I'm printing.
Okay. What do you do if you think the patient doesn't have capacity, or if you think that the patient might have a bit of a problem with the memory? Does anyone know?
So we'll check the memory, like we'll ask him to repeat something after us. We like to check in the way, like repeat 2-3 words, and then we'll say, can you please repeat it? To check.
A mini mental state?
Yeah.
Mini mental state.
Yeah. So there are various different types of ways to test cognition. Under the components of the mental state exam, do not do a cognitive assessment. Does anyone know how long it takes to do a comprehensive cognitive assessment?
Ages.
Months. Yeah, it takes months to do a proper one. And the most comprehensive of this list is the Addenbrooke's, the ACE. It has 100 items on it. If you think the patient has a problem with cognition, you ask them, are they orientated to place, person, and time? Concentration, you don't have to ask. Concentration, you will gauge from having went through your entire history. For memory, there are 2 questions that you ask, or 2 types of questions that you ask. Does anyone know?
Do you know who you are? I'm not joking.
So you ask,
I'll tell you 3 words, and then you can repeat them after me once I've asked you after some time.
I think that's a component of the MMSC.
Dates of the Great War?
No, so what I was trying to get at, if you think that someone has a problem with their memory, there's a very, very simple screening test that you can use. And it's literally 2 components, right? You test the short-term memory and you test the long-term memory. So how do you test someone's short-term memory?
You could ask them if they remember your name or how you introduce yourself.
What did you have for breakfast?
That is the perfect, most brilliant question that you can ever ask. What did you have for breakfast this morning? What about long-term memory?
The Great War. Or
Anything that happened, any significant life event or any significant world event that happened. You can ask them about, do you remember your wedding, your first pet, your mother's maiden name, anything that they would need to have an intact long-term memory for. Okay. If you suspect that your patient has a cognitive a problem don't go on to do a cognitive assessment or a cognitive test. Keep it at the back of your mind and make sure you mention it in your summary and say, I would like to do a full cognitive assessment for this patient. Yeah. Insight is also important. So more often than not, mental health patients do have some insight. Okay, so in personality disorders, they sometimes have insight. Behavioral disorders. What's the mental health disorder when they would not likely to have insight?
Eating disorders.
Fantastic.
Schizophrenia.
Yes, and psychosis. I don't know if anyone has actually seen a psychotic patient. Has anyone actually seen and interacted with a psychotic patient?
Yes.
Yeah.
Yeah.
So they have absolutely no insight. They do not know who they are, where they are, what they're doing. They are just psychotic, manic. Okay. The third part of the psychiatric assessment is the risk assessment. I'm sure everyone knows your red flags. And you can use the acronym SUICIDE. It's easy to remember because it's suicide and you're asking about suicidal thoughts and plans. You don't have to ask everything. And these are just the headings. It's a nice, simple way for you to remember it. Risk to others, you must ask this question. Okay, so often patients will be seemingly fine. They'll say, I've never had any thoughts of suicide. I would never hurt myself, doctor. Absolutely not. My energy levels are fine. I get 8 hours of sleep a night. I'm eating. I have all these hobbies I like to do. But they have behavioral issues and they do get these emotional swings. So emotionally unstable personality disorder, and they do cause risk. They do cause harm to others. You must ask this little section, risk to others. Are you upset with anyone? Do you think that you will hurt anyone? Do you think that you will hurt me? Any questions about that?
Nope.
So I've given about 4 examples of how you should structure your impression and your summary. These are very straightforward. It's literally 1 sentence or 2 sentences. I think this is fairly straightforward, but if anyone has any questions, now's the time to ask. This basically shows the examiner that number 1, you're paying attention, you know your patient's name, and you know their age and gender, and what you have assessed for, and what you're thinking down the lines of. The 3 most commonly tested stations in the psychiatric assessment or psychiatric history taking station are depression. Depression has come up quite a few times in the past. Psychosis / schizophrenia, and anxiety. It's a bit rare to have anxiety. I don't think it's come up for a few years now. So for the past few years, it's either been moderate to severe depression or psychosis. So that was just a quick overview of the components of the psychiatric assessment guideline that I've given you. Questions?
Nothing on the chat.
I honestly thought they
Can you ask insight as part of the history, the first part, at the end?
Sorry, what was that? Can you please repeat that?
The insight, when you ask about insight,
Yeah.
Can it be asked as part of the history taking, like the first part of the assessment, or does it have to be with the mental state examination?
It is a component of the mental state examination, but why I've structured it out in that manner is so that you can have structure to what you're working through in your head. But you can ask the questions in whatever order you want, as long as you get through all those headlines.
Okay, thank you.
If you prefer to ask about insight at the end of your history, that's absolutely fine as long as you ask about it.
I think something that we have been struggling with is when practicing depression stations to actually get to make the patient, like break that moment where the patient is talking about something else, but you are picking up that is the mood that is altered, and then how to switch like from the first history to actually go deeper into the depression and the mood. So we have find that difficult, especially to manage with time.
So are you talking about like the pauses that you need to take?
No, like the example I just mentioned about the sleeping disorder.
Yeah, so, but I guess, I don't know, someone comes to you saying that I don't know how the station would be, because I'm not sure if they would actually say to you that the person is coming because he's feeling low in mood. I don't think that would be the case. They would give you another reason for this station, or would they tell you?
They would not give you the exact reason for referral. So that's the main part of the station. You have to elicit the diagnosis yourself.
Yeah, so that's where we have been having difficulties, like trying to break that ice and, trying to get actually into the mood and the psychiatric history.
I understand. And I would just like to say that the actors are extremely good. So the patient actor that I had, he was a young lad. I think he must have been like in his very early 20s or 19 or something. And he was acting, but he acted really, really psychotic. He was such a brilliant actor, and it was just absolutely amazing. So he was turning his head, listening to things. He was telling me that some devices were talking to him, and he just burst out at a certain moment saying that the Americans are after him. I remember that station very, very vividly. So don't be concerned about getting into the mood of psychiatry. The patient actors are really, really good. So a depressed patient will be really depressed.
So what Laura said, I just want to add it. For example, if the lady has come with sleep disorders and she maybe she is drinking a lot of tea and coffee, taking a lot of caffeine, and has lost her husband, so she's got bereavement. So yeah, that's the thing, like how we are going to move from the normal history, sleep problems, to like how we know that this is going to be a psychiatric one. Is she is in depression, or she's just because she could not sleep because of the caffeine she has in her diet?
So the patient will be very obviously a psych patient. If the patient that you're describing to me would appear in the exam, that actor will be not making any eye contact with you. So I'll go through the mental state exam. I'll tell you what to look for. No eye contact with you. He or she will usually be wearing like really dull, drab clothes. The hair will be all messed up. It will be a skill that you need to do. So you will need to go through the mental state exam and try and find out that it's depression. If it's too obvious, it's too easy, it's still an exam.
Now I get it. Yeah. From the looks of the patient, you have to decide.
I'm not really sure if that makes sense, because if it's too easy, if they tell you this is a patient with depression or having a bit of a low mood or has just lost a husband or has been having insomnia for a while with loss of appetite, it makes it a bit too obvious.
Okay,
and
thank you.
it doesn't really give you anything to do in the station.
There's another question saying, do you have to get the diagnosis right? And also, do you have to give the reason for your diagnosis?
Yes, there is only one right answer in these stations. You have to get the diagnosis right. Like I said, What you guys have been saying is correct. They can give you a depression case, but with a different presenting complaint, and you will have to figure out that it's depression. So the insomnia thing is really good. The patient can say, doctor, I'm having I'm having a difficult time trying to sleep. And then when you elaborate more and go through your assessment, you'll end up finding out that it's a psychiatry station, and then you'll know, switch and start doing your psychiatric assessment. It's only ever going to be depression, psychosis, and sometimes anxiety. Don't learn behavioral disorders, PTSD.
Anorexia?
Anorexia, we can go over anorexia, but I'm not really sure the last time that's come out. Does anyone know if I'm looking at the past feedbacks?
No, I'd have to check.
Yeah, not on the top of my head. So somebody's asking, so if it is too obvious, it's not the diagnosis?
Now you're thinking too much.
And
If it's obvious to you, is probably the right diagnosis.
You know, maybe what would be useful is to, I don't know if you have, you know, like clinch or a phrase, something that you can use with the patient to actually open up to you. Like from your experience, how would you make that patient that is talking about something else, but you notice that the patient is looking down, that the hair is messy. How do you actually tell them, hey, I noticed this or that, it's everything okay? I mean, you know, like how would you actually ask if you have anything from experience that you could let us know?
It's very, very dependent on the case that you get. You don't ever comment on the patient's appearance. That's a bit rude. But if you notice that they're looking around the room, you take note of that and you ask them, Jonathan, are you hearing anything? Or what are you looking at? And because it's a patient actor, they will elaborate and they will tell you, can't you hear that voice? And then you go on, what voice? Where is the voice? Is it male or female? Is it talking to you or at you? And then you go through your questions like that.
Yeah, anorexia came up in 2018.
Then go through the anorexia.
And then someone else asked, what about bipolar or a manic episode?
Manic episodes, yeah, mania and psychosis. I will go through the main ones. So the main ones are depression, psychosis. Mania is very, very obvious. I'm not sure that they would give you bipolar, because bipolar affective disorder comes in a range. It presents in a very similar way to psychosis, so that shouldn't be an issue. All you do is in your differentials, in your summary, you mention your differentials. I think this is psychosis based on the patient was hearing voices, had delusional perceptions, had no insight in your first rank symptoms, but I would need to further evaluate for bipolar disorder.
So Rishka, say you're in the exam and you realize it's a psych station and you totally blank it. What are the main things you need to make sure you don't miss just so you can pass?
If you forget everything else in the station, remember the mental state exam. Okay? If you forget all the components, all the questions that I've sent, do the mental state exam and you will pass. The mental state exam is the crux of the psychiatric assessment. And a lot of the mental state exam incorporates some of the questions that I've shared already about thoughts.
Beautiful.
So that would be like the orientation, concentration, and memory, right? No, that's cognition.
No, so I'm going to go through the mental state exam now.
All right, okay.
Any other questions? Psychiatry it's not easy, and I will be very honest with everyone. I did pretty well in the clinical assessment exam. I scored highly in all the other stations. The only station that I failed was the psychiatry station. And it's only now, as a FY2, in psychiatry that I realized why. And that is why I'm sharing this knowledge with everyone.
So somebody's saying, my PLAB teacher said, never say psychosis as a diagnosis. Is that right? What should we say then?
Why should you not say psychosis as a diagnosis? You're querying psychosis. You say query psychosis. Query psychosis, query new onset psychosis, query mania.
No idea.
Can we
But
say
no
acute
answer.
psychosis?
Well, depending on the
Can we say acute psychosis?
Psychotic
Because-
episode would be the most accurate description of it.
well, depending on
You can say query psychosis or query new onset psychosis. So there's something called an early intervention team, EIT. What they essentially go and do is primary care providers in the community flag up certain patients with psychotic symptoms. And the early intervention team goes and evaluates them, and it has to be between 4 to 6 months, because that is a crucial time period of when psychosis is best treated. So if it is after that, the patient most likely ends up with long-lasting negative symptoms, which no amount of antipsychotics.
Wouldn't like if it's been less than a month, wouldn't that be brief psychotic disorder, and then 1 month to 6 months would be not schizoaffective, and then more than 6 months is schizophrenia?
I'm really sorry, but you have a lot of background noise there.
I think
He's
you
at a
said,
party.
yeah, sorry.
Can you repeat that?
Sorry, I think what he's trying to say is that if it's within 6 months period, with, should we say, acute psychotic episode, and when it's more than 6 months, we should say, is it schizophrenia?
No, because
I think.
no, because this is a night. You guys are thinking too hard. Okay? It's not a hard exam. You're not psychiatrists and you're not psychiatry core trainees. So you all you need to do is recognize that this could possibly be psychosis, and you mention that to the examiner. Give a sensible list of differentials, and that's it. Your job is done. You can't say it's schizophrenia based on this one assessment. Psychiatric inpatients stay with us for months, and at the end of that time, we still usually don't have proper diagnoses. So it is impossible, and it's a bit inappropriate for you to say this patient has schizophrenia at a 9-minute assessment.
So another question is, what differential should we have to rule out for depression, psychosis, anxiety, and anorexia respectively?
Oh my goodness, that is a really, really long question. Maylin, can you please put that in the group?
I will do. And then the next one is, do they use DSM-5 in the UK?
I think DSM-5 is more of the DSM-5 criteria is, we actually use ICD-10 and the ICD-11 is coming out now. We use both of those codings, but you don't need to worry about the coding at all. The secretary will do the coding for you.
Yeah, I have experience in that. In
Yeah,
coding.
you don't need to do the coding at all. I think you guys are they're thinking too hard about the station. Okay, so it's psychiatry. Yes, it's a little bit scary. I can empathize with that. But ultimately, if you just do everything, you get 3 just fine.
Beautiful, thanks.
Please don't panic.
And what do we do if we don't panic?
Right, I'm trying to get this back up on the screen. So
Panicking is our
no, don't panic, don't panic. Can anyone see the slides?
Nope.
No. Okay, so I need to go back to share screen. And I need to go there and share, and that should be coming up now.
Yes.
Right. Has everyone watched all the video playlist that I sent?
Nope.
No.
Are those the like example stations with the actors?
Yeah. So what
Yeah,
I
I've come across them. They're good.
yeah, so what I wanted to do is for a lengthier session, but I'm honestly exhausted, was what I wanted to insert certain clips and show you guys how certain types of patients present.
Yeah, it was exactly that. Very helpful.
So this is a short PPT on just some aspects of the mental state exam. Does everyone know what the mental state exam is?
Yes, maybe.
It's an examination of the mental state.
Very clear.
You can interestingly do, so on my own calls, if patients were really psychotic, you can do 50 to 60% of the mental state exam without saying a word, just by observing. Okay. So all that the mental state exam is you observing the patient and reporting on your findings. So you need to be a very observant individual. It's used together with the psychiatric history to both suggest evidence for and against diagnosis. And what this means is the mental state exam in conjunction with the psychiatric history is very useful at ruling in mental state or mental health diagnoses, but it's also useful at ruling them out. These are the aspects of the mental state exam. You need to learn these. All of these off by heart. Appearance and behavior. Some people do appearance and behavior separately, but I always do it at the same time because they both involve observation. Speech, mood, perception, thoughts, cognition, insight. Some people do capacity at the end, but you would have all known and you would all done a capacity assessment and practice before. Am I right?
Yes.
Yes. You all are experts at the mental capacity assessment. So I don't need to go through mental capacity. So appearance and behavior, exactly as the title implies, you're just looking at the patient. How do they look? What age are they? How are they dressed? Is there any odor? So often the first thing you notice in depressed patients is not how they look, but it's how they smell. Okay, you get that smell of an unwashed body, of stale sweat. And that's very, very telling. So use all your 5 senses, not just your eyes, in observation. Are they making eye contact? Yeah?
I was going to say, how do we smell over Zoom?
That's a very good point. And you got me there.
Smell your dog.
They can tell you a spray in the chat that you should smell this. He's just smelling like that.
Yeah.
Yeah, you got me there, Luke. Fair play. Are they making eye contact with you? Are their eyes going everywhere around the room? Or are they just kind of staring down? Are they crying? Are they gesticulating? Are they socially inappropriate, trying to get into your body space? Are they very violent and aggressive? If they're violent and aggressive, what do you do?
I'm back.
You run away. You open that door and you leave. You say goodbye, call the consultant tomorrow. This is not my problem anymore. Are there any abnormal body movements? Or do they have any weird tics? Are they jiggling their legs a lot? Very good sign of anxiety. Can you perceive any response to external stimuli? Okay. I think it's fairly straightforward. You just have to be extremely observant, and what can be a very useful way of this component, getting practice in this, is just people watching. Okay, go out to Tesco and just people watch.
So
End of
nice.
section, everyone.
I don't end of section. So just by the way, you cannot do so. Does anyone know really about the Mental Health Act and the sections?
A little bit, yes.
Yeah, a little bit.
So the section 2 and 3, so admission for assessment and admission for treatment. The first one is section 2 is 28 days. Section 3 is up to 6 months. Junior doctors cannot do section 2s and 3s. You need 2 independent people to do a section 2 or section 3. One has to be an AMP, so an approved mental health practitioner, and the other has to be section 12(2) approved. So they have to be pre-approved by a judge under section 12(2) of the Mental Health Act. And those 2 people will do a psychiatric assessment, an initial assessment, and they will come to a joint agreement. Then they have to file papers, and the patient is on a section 2 or section 3. And it's done pretty quickly because there's sectioning on call, there are AMPs on call. So it can happen at midnight, it can happen at 3 in the morning. It's been done before. Actually very good with sections. Do you know what is the only section that a junior doctor can do?
4?
Section
Deprivation of liberty.
5.
It's a section 5(2). So section 5(2) of the Mental Health Act is what a normal doctor like me or a med reg can do. But in order to do this, the patient cannot be in the community. It means they cannot be on the streets. They cannot be in a primary care facility, such as a community mental health facility, a crisis care center, or GP surgery. They cannot be in A&E. You cannot do a section 5(2) for a patient that is in A&E. That is illegal. You can only do a section 5(2) if the patient is admitted in hospital. That means they are on the system, whatever system they use, Medway, Lorenzo, whatever, and they are under a named consultant. And if you go and assess the patient and assess that they do not have insight and they do not have the mental capacity to make their own decisions, then you, as a junior doctor, not an F1, so F2 and above, you need to have full GMC registration for that. You can institute a section 5(2). This is the reason why that F1s don't do psychiatry on calls. It's because of the sectioning, and it's because of the drugs that need to be prescribed. So you need full GMC registration for that. This is not really something that you need to know, but it's interesting. Do you have any questions about sectioning?
Nope.
No. Okay. So speech, the same as appearance and behavior. How are they talking? Are they talking at all? Are they mute? Are they in a catatonic state? They're just not talking. The quantity, rate, and volume. The quality of the speech. Is it of an adequate quality? Is the patient trying to grasp at words? Are they using inappropriate words? Are they using incomprehensible words? Okay, and is it appropriate for the conversation that you're having? Now the mood. So when people say that they have interchanging moods and their moods change all the time, that's not technically correct. There's 2 aspects that you need to assess, and that is the mood and the affect. And a very nice analogy is that the affect is like the weather and your mood is like the climate. So in order for the climate to change, you need to have weather that is present for a certain amount of time. And that is exactly what happens in the mind. So your mood becomes pathological when the affect is severe enough, is present for a long enough period, and it is present constantly. It's a bit of a strange concept to understand, but is everyone kind of on the same page with mood and affect?
Would be kind of like an emotion and a feeling in a metaphorical kind of way.
Yeah, precisely. You can think of it as that, or you can use any analogy to kind of explain it.
Beautiful.
Perception. Does anyone know what perceptions are? Or what the word perception means?
Anything you perceive through your senses.
Yeah, so it's what the patient sees. And we all see the world in different ways, right? How you perceive the world is governed by your 5 special senses. So your smell, your touch, taste, sight, and hearing. It's also governed by your muscles and joints and your internal proprioceptors. Your vestibular apparatus also gives perceptual information. It's a very complex, kind of confusing flow chart, but I'll explain it. So your external object gives rise to your sensory percept and combines with your memory and experience for a meaningful internal percept in the conscious mind. What does that mean? This is a pen. Does everyone agree this is a pen?
Oh.
No.
Never.
Yeah, we do.
This is a pen, yeah? This is my external object, and I'm holding this in my hands, and I'm looking at it. So my sensory percepts, tactile and visual, right? So external object, pen, I'm touching and I'm seeing the pen. Now these sensations go into my conscious mind, and it combines with the memories and experiences of what I know pens to be, yeah? And together, that creates a meaningful internal perception in my conscious mind. And that is how I know that this is a pen. Does that explanation make sense?
Yes.
Yeah. So healthy individuals, even if they are sick, are able to clearly distinguish fantasy from reality. Has anyone experienced any hallucinations?
Maybe.
Kind of. Yes.
Depends who asks.
Not a psychiatrist, that's for certain.
Or the police.
So I have experienced hallucinations. I was really, really sick. I had a horribly high fever. It must have been like 39, and I was hallucinating. I saw red horses running down the hallway. And even in that state, I still realized that what I was seeing wasn't real, because there was absolutely no way that there were horses, red horses, running down the hallway of my house. Yeah. So what it means by healthy individuals, they can see something, they can be hallucinating or hearing things, but they can very sensibly understand and come to the conclusion that what they're seeing is, or perceiving, sorry, perceiving is the correct word, is not real. Right?
Yeah, we all had fevers.
We all have fevers. So perception becomes abnormal when it is altered. And there's 2 types here. There's altered perceptions when there is a distorted internal perception of a real external object. So this is a real pen, but my mind understands it as a snake, just for example. Okay? And there's a false perception. These are your hallucinations, is where there's nothing that exists in the external world, in the real tangible external world, but you have this internal perception of it. Perception was a bit tricky. I know it can be a bit tricky to understand, but hopefully that gives everyone a bit of insight as to what perception is. And that's why I focused on this portion. I think it's really important to understand something before you're asked to do it.
Definitely very clear. Thanks.
So in terms of your thoughts, I won't go through this in detail because all the questions on thoughts I've already supplied to you. And again, you do not have to ask all of them. You ask some of them, or you ask the ones that you think you should ask. The only way to assess is to ask. What happens if the patient doesn't want to answer any of your questions? What do you do if the patient doesn't want to answer any of your questions?
Non-communicative, so you already answered speech.
Can you mention confidentiality?
Come back another day. Cognition, I have explained in detail about this as well. So your level of consciousness, are they awake and alert, looking around, or are they unconscious and you have to put out a medical emergency call? Okay. Do they appear confused to you? Okay, so are they orientated to person, place, and time? Are they kind of misinterpreting anything that you say? So a certain level of misinterpretation, I think, is forgivable. Okay, not everyone is exactly on the same page, but generally they should understand what you're trying to say, and they should be able to comprehend what you're trying to say. Okay, and the memory I've talked about. I've already given you the answers to the types of cognitive assessment that we use. The 6-sit is the easiest, simple 6 items, beautiful assessment. I love it. The easy bedside assessment. The MMSC is 30 items, is it? It's a bit of a more lengthy one. I know it comes out in PLAB a lot, or it used to. I'm not really up to date on PLAB 2 at the moment. And the Addenbrooke's cognitive examination, the ACE, is the gold standard for cognitive assessment. It's a 100-item questionnaire. It takes a while to do. Don't do it in the exam. Insight. This is a very textbook definition of insight. It is the correct attitude to a morbid change in oneself. If someone is sick, they should be able to recognize and understand and acknowledge that they are sick and have the correct attitude. Okay, so if I'm suddenly diagnosed with cancer, the correct attitude to a diagnosis of cancer is depression, low mood, okay, and everything that you will find in a patient with depression and low mood. So low eye contact, not sleeping, not eating, etc., etc. Can anyone give me a really, really common example of lack of insight? And I'll give you clues. That you'll see this on geriatric wards.
I'm not losing my memory.
I don't know, my mom just brought me. There's nothing wrong with me, doctor.
So all of those things above. Typically you get this elderly patient, this really cranky old man, accusing everyone of stealing his stuff because he can't remember where he's put them. Okay, that's a really simple example of a lack of insight. Capacity can be assessed without asking any particular or specific questions. You will gauge the patient's capacity, or if they have capacity to consent to treatment throughout your assessment. And inside, you need to ask, do you think that there's something wrong with you? Do you think that you need help? Do you think you need to be here with us today? I've already shared this really excellent playlist in the group. If I had the time or the energy for a lengthier session, what I would have done is taken small clips out of this video and put them under different headings. So this is a patient with depression, this is how they look like. This is a patient with psychosis, how they look like. This is a patient with a blunted affect, this is what they look like. That is the end of my set of slides. And is there anything that you want to ask me?
Yeah, so we have been, so sorry, there was a question before that I didn't say because I thought it was pertinent to say at the end. The question was, so we report the patient's mental state exam to the examiner?
No, you report the summary to the examiner. So your mental state exam will form part of your end summary.
And then there is a book that we've been following for OSCE cases. So we were wondering if you were up to doing like 9 minutes a station and Luke can be your patient.
Tonight, I honestly don't think I have any.
Right. Oh, okay. No worries. We just made him run to get the book.
Oh, what's the case?
It's I won't tell you. So the prompt is like I tell you the prompt. Just a sec.
Is it the lady with sleeping problems?
No, it's you're a junior doctor working in the A&E. Mrs. Jamieson has been brought into the department by her work colleague as she has been causing a nuisance at work and is behaving oddly. Please take a focus history and formulate a management plan.
That's probably mania, isn't it?
Yes, psychosis.
I have a question in that regard. So when the station has two people, so in this case, for example, they have the patient who was brought by one of the colleagues. Do you go to the patient or do you go to the person that is with the patient?
Or is that likely to happen at all?
No.
Or it's been always only the patient?
It's always only been the patient.
Oh, good.
So sometimes the so I'm just remembering the case that I had, the young lad with the schizophrenia / psychosis. The STEM said that his mother brought him in, but the mother isn't there in the station. It's just the examiner and the patient. And this would be very different on Zoom.
Right, there's no other questions in the chat.
Sarishka, sorry, I'm just wondering, I know you'd said that like probably the most essential thing that you do is the mental state exam, but how do you communicate to the examiner that that's what you're doing if they don't specifically ask you about it at the end?
You can say something really simple like, that's a really good question actually. You can say, I'm just going to do a short assessment of your mental state.
Okay.
You could kind of signpost to the examiner what you're doing and how you're thinking. I would honestly always do something like that because the examiners, they do pay attention. I mean, they're there to pay attention to you, but you can't always guarantee that they know what you're trying to do. So I would always try and make it as obvious to them as possible.
Right. Thank you.
Okay. Anything else?
Nothing on the chat.
Sorry, just, you know, the way it's like the 2 minutes with the examiner, what kind of questions can we expect?
The examiner will only ask you one question. What's your diagnosis and why do you think that? So if, for example, you're talking about, so in your summary, this is a 43-year-old lady you presented with insomnia. Her husband passed away 6 months ago. That might have been the trigger for this episode of depression. My main differential is depression. My secondary diagnosis could be depression with anxiety. Just say it like that.
Sorry, I've got a quick question. I just realized. So does that mean that we would have to, like, after kind of examining the patient with MSE and stuff, and let's say you've come up with a diagnosis, before the examiner asks you anything, would you kind of be expected to give a diagnosis to the patient and kind of talk about how you would manage it, or would you just talk that straight to the examiner?
So you would typically do, it's very variable in the way that you do this. I would do it for a patient with depression. I would not necessarily do it if I'm suspecting psychosis or mania, because there's no real benefit in doing that. You just be wasting your time. You would kind of do that anyway when you're assessing insight. So you can say, do you think you have a problem? The patient will say, no, doctor, I'm absolutely fine. When can I go home? Then you can say, I think you might have a bit of a mental health problem. I think you might need to stay here with us for a while. What do you think about that? And then you can go down along that line.
Okay, thanks. That makes sense. Thank you.
Another question in the chat is, should we incorporate risk assessment in the middle of the history, or do we do it in the end?
You can do, again, you can do it whenever you want to, as long as you do it.
Next question is, oh,
sorry, what was that?
Sorry, my dog was barking. Would you she's still barking. Directly say to the patient, I'm going to assess your mental state?
Yeah, you can say, so like I said, make it very obvious to the examiner that you're going to do something, because they can't read your mind. And it's better that you let them know directly or indirectly what you're going to do and how you're thinking along the lines of. So just say, I'm going to have a little assessment of your mental state now.
Next question is, do we ask ICE and psych history?
It's very dependent, again, on the station. If it's depression, you can ask it. If it's psychosis, there's no real benefit. You would assess those ICE questions in Insight, wouldn't you? Ideas, concerns, expectations. So,
and next up is, how do you start, well, maybe like the same as Laura was asking before, how do you start the station if the patient is down or doesn't talk? Any punchline or icebreaker?
You know, unfortunately, some patients just do not talk. And so as F2, when I do clinics, I get 30 minutes. That's a luxury. And sometimes you're there sitting there for 30 minutes trying to get some kind of response on the patient, and there's just nothing. What you can do is you just ask your questions, you wait for a few seconds, and you move on. The main so you'll get most of your answers then from the mental state exam. And you can still make a diagnosis even if the patient says not a single word, but I promise you the patient will talk.
No further questions, Your Honor.
Okay, so if that's it, just please put your questions in the chat. I will get back to it sometime. Hopefully, I'm going to sleep now.
There's a last one. Can we say about confidentiality to get them to talk?
Yeah, absolutely. So these are generic communication and history taking skills that are very transferable across all stations. It's not necessarily you need to stick to one thing for medical and surgical consultations and interviews and do a completely different thing in psychiatry. So this is very transferable skills. If you think the patient not talking to you because of a confidentiality issue, say, I'd just like to assure you once again that this session or this interview is completely confidential. However, you should be saying that anyway as a standard part of the introduction.
Beautiful. Thank you very much.
Okay.
Thank you so much, Sarishka.
Thank you.
You are a blessing for us.
Thank you, Sarishka.
Thank you. Thanks. Good night.
Thanks, Sarishka.
Good
Have a
night.
good sleep.
Thank you.
Thank you.
Bye.